So I'm going to start a new section on diseases. The first one we're going to talk about is COPD. We're going to start with talking about the definitions, the GOLD definition and the ATS definition. We're going to talk about the special characteristics and the definitions within this disease process that as respiratory therapists and as clinicians we should do a really good job of with treating and educating so that we can ultimately lead to better patient outcomes. So here's my first part of COPD.
All right, gang. So we're gonna be talking about COPD today. This is the bread and butter for respiratory therapists. This is what we are kind of designed and programmed to be able to identify, to be able to treat, to be able to classify, and give recommendations on. So we're going to talk about COPD today. We're going to talk about the classifications. Now, when we talk about the classifications, I know so many of us know about CBAVE, right? But whenever I look at this, I really want to break it down and separate the bronchiectasis, the asthma, and the cystic fibrosis from the chronic bronchitis and the emphysema. These two, really, these chronic bronchitis and the emphysema are the two that really are the two main players in COPD. Now, yes, bronchiectasis, asthma, and cystic fibrosis do play a part, but I'm going to give those a separate video that they get plenty of recognition for. So when we start out and we look at when we look at when we look at COPD, there's two different definitions, right? There's this ATS definition and there's this GOLD definition. The ATS definition says it's a preventable and treatable disease. It's a preventable and treatable disease state characterized by airflow limitations that is not fully reversible. That's the ATS definition. Now, the GOLD definition runs a little bit further. Okay, again, it's a preventable and treatable disease with some significant extrapulmonary effects that may contribute to the severity in individual patients. Its pulmonary its pulmonary component is characterized by airflow limitations that is not fully reversible. The airflow limitations is usually progressive and associated with abnormal inflammatory responses of the lungs and noxic particles or gas. And noxic particles simply mean things that are hazardous or can cause harm to the patients. Now, when we get to the specifics of chronic bronchitis, and we're talking about our blue bloaters, let's go back just a second. I did these in blue so we could identify that these are the blue bloaters, and we have the pink puffers right here coming in with the emphysematics. So if you were to think about those two in that sense, that's kind of how we like to exteriorly define those two disease processes. So when we talk about chronic bronchitis, it's the chronic productive cough for 3 months in each of two successive years in a patient whom other causes of productive chronic cough have been excluded. So with our chronic bronchitis patients, right? I'm going to just go CB here for expedited measures. Chronic bronchitis, these have 3 months of productive cough for 2 plus years, 2 consecutive years. When all of the other disease processes, all of the other rationales have been excluded. Okay, excluding excluding um, other causes. Now with emphysema, our emphysematics, again, we're going to call those our pink puffers. Okay, so we've got our emphysema patients. Those folks are going to be, they have a permanent enlargement of air spaces distal, so further away to the terminal bronchioles, accompanied by destruction of the bronchial walls and without obvious fibrosis. So we've got permanent damage, basically. Permanent damage. Distal to the terminal bronchioles. And and increased airspace. I'll go ahead and write out increased, or I'll just do it, increased airspace. Okay, so these are the things that really kind of define both chronic bronchitis and emphysema. So we've got both gold standards, ATS, but when we talk about chronic bronchitis, that's really what we're talking about is 3 months productive cough for 2 consecutive years that excludes all other rationales for having that cause. And then with emphysema, a permanent damage to the distal, permanent damage, um, permanent damage distal to the terminal bronchioles with increased airspace. Now, anatomic alterations. Now, we can go all day about the anatomical alterations with chronic bronchitis and emphysema. And really, these two illustrations, or this one illustration right here, brings the idea of the pink puffer and the blue bloater to fruition, right? So if we look at this and we go chronic, so with chronic bronchitis, we're looking at chronic inflammation and thickening of the walls of the peripheral airways with excessive mucus production and accumulation, right? So again, chronic bronchitis, looking at chronic inflammation and thickening of the walls of the peripheral airways, and that's in the peripheral airways. Okay. Now, one of the other characteristics is partial and total mucus plugging of the airways. So we have increased mucus production that creates a either partial or total blockage. Okay. And what else do we have here? We have smooth muscle. So number 3 here, we have smooth muscle constriction. We have smooth muscle constriction of the bronchial airways or a bronchospasm. Okay, smooth muscle constriction of bronchial airways, aka bronchospasm. Okay, and then 4. And this isn't always, this is kind of a variable finding, what they call a variable finding. It's not in every chronic bronchitis patient, but it's usually in the end stage. So to the end stage or the latter stages of chronic bronchitis, you have air trapping. Okay, so it doesn't. Another name for that is alveolar hyperinflation. So when we talk about all of these different names, sometimes we get into like the alphabet soup of things. Um, just understanding that what we're doing in healthcare and what we're doing when we're learning these new um, definitions and terms and things of that nature, what we're trying to do is we're trying to teach you a new language, right? And if you understand that learning a new language takes lots of practice and takes lots of effort and attention, then you'll understand that the more reps you get with these words, the more times you hear it, the more times you use it in a conversation, the better you will feel about discussing them or using them in conversation and truly understanding the meaning behind them. So now let's jump into emphysema, right? So emphysema is again, if we go back to the definition, is permanent damage of the damage distal to the terminal bronchioles. So we're going to have again a permanent enlargement, and destruction of the air spaces. So this is when you get to that point of having that balloon, and you when you get to that point of over inflating a balloon too much. This is what happens here. Okay. All right. Let's go back here. So all right. So when we start talking about the anatomic alterations of emphysema, when we start talking about emphysema, we're talking about the permanent enlargement and destruction of the air spaces distal to the terminal bronchioles. What we're talking about is the overexpansion, the hyperinflation of the air spaces of the alveoli, and then closing those back down and just wearing out the elasticity to where that patient has no more recoil. So again, the anatomic alterations for emphysema, we're going to go back to that definition. It's the permanent destruction of the airspace distal to the terminal bronchioles. Let's spell that right. Distal to the terminal bronchioles. The next thing is we're looking at the destruction. So emphysema is like, it sounds like just a rough go, right? We've got destruction in two of the anatomic alterations as key characters, as key, contributors to what's going on. So destruction of the alveolar capillary membrane. So we've got alveolar capillary membrane. Then you have weakening of the distal airways. So with all that destruction, if you were to think about it, right? If you were to think about tunnels or bridges, right? And you lose some of the structure to those, then they're not going to be as effective. They're not going to work as well as they should. A lot of times they make crush or crumble. So you'll have weakening of the airways, and that is another byproduct of the destruction that's going on. So we have weakening. And then lastly, this isn't like an end stage like you have with chronic bronchitis. This is early, right? You have that air trapping. This is that classic sign. Air trapping and alveolar hyperinflation. So this is just a quick overview of what we've got with our COPD patients, particularly the chronic bronchitis and the emphysematics. The bronchiectasis, the asthma, and the cystic fibrosis patients, those will get a specific video. Yes, they're within the classification of CBABE, but typically when we talk about COPD as the key contributor to, or the key contributors to COPD, we're really talking about chronic bronchitis and emphysema. So I'm going to highlight those. We got chronic bronchitis and emphysema. Those two right there are the key contributors. Those blue bloaters, those pink puffers are the big players in COPD. Again, chronic bronchitis, you've got that productive cough for 3 months for 2 consecutive years. And with emphysema, you have permanent damage. There's destruction going on to the airways and the air spaces. If you see the picture of the emphysematic, you see the pink puffer here. And with that chronic bronchitis, you've got that big blue brute that's coming at you. You've got your anatomic alterations here, and plenty of information to start with as you begin your journey into understanding COPD.